Okay, I'll go ahead and get started now that it's been a couple minutes. Lovely to meet you all. My name's Jackie. I am a third-year medical student and a member of Doctors for America. Before we get started, I am the person moderating today, so I'm going to kind of go through this general spiel, talk about our speakers, and then I will let them have the floor. I wanted to take a quick minute to invite you to officially join Doctors for America, or DFA. Being a DFA member today means taking the important and simple step of selecting a membership level and paying your annual membership dues to support DFA's organizational sustainability and incredible programs like this Advocacy Grand Round series. There are 4 different levels to choose from, and Raya, one of our DFA team members, is going to put the link in the chat to join. Thank you, Raya. We'll be making a recording of this. We'll provide all the materials that will be available to you afterwards. We have actually a very handy guide to provide to you afterwards, kind of summing up what this session is talking about. And a few quick ground rules for this educational session. 1, there's no such thing as a stupid question. And 2, please remember to use the Q&A feature to leave questions. We'll address them kind of towards the end, and look for comments in the chat. Raya will continue to share helpful links throughout the session. This event is entitled Physicians Needed, Medicolegal Physician Advocacy, and this is our November Advocacy Grand Rounds. The aim of this event is to provide an overview of the many different pathways physicians can participate in to assist immigrants, refugees, or asylees in their many paths to determine permanent residence or citizenship. While we won't be providing exact instructions on how to go about these services, our aim is to provide you resources going forward if you wish to train in these different pathways. Now on to our speakers. We are thrilled to welcome first Shanna Stryker. Dr. Stryker is a physician double-boarded in family medicine and psychiatry and fellowship trained in global health. She is the co-director of the Office of Global Health at the University of Cincinnati College of Medicine and the medical lead of a medico-legal partnership with the Immigrant and Refugee Law Center, a nonprofit law center in Cincinnati. Next is Nicole Bashir. Dr. Bashir is a volunteer associate professor of pediatrics with the University of Cincinnati, practicing general pediatrics at an outpatient clinic associated with Cincinnati Children's. She was the director of refugee health at the University of Louisville for 5 years and teaches about immigrant health, ethics, climate change, and global health. She is a pro bono civil surgeon and has worked with several types of medico-legal partnership for immigrant advocacy. And last but not least, Nicole Damari. Dr. Damari is assistant professor of internal medicine and pediatrics at Cincinnati Children's Hospital at the University of Cincinnati, where she works clinically as a med-peds hospitalist. She is an associate program director for both the med-peds and internal medicine residency programs in Cincinnati. Her non-clinical interests include physician advocacy, medical education, and medical humanities. And now, without further ado, I'm going to leave it to our speakers to begin their presentation.
Good evening, everyone. Now is when I struggle with the tech, even though I promise I practiced this. Give me just one moment. And I think you're all seeing one big screen. Can I get a thumbs up? Awesome. Great. Thanks so much, Jackie, for the introduction. And I'm just going to launch right into it because we have a lot of content to cover and we want to make sure that we leave time for some Q&A at the end. So we're going to, again, talk about the different scope of immigration pathways, how physicians can help at different stages of the immigration pathway for legal immigration, which is very complicated. Disclaimer, we are not attorneys. However, we've worked with enough attorneys that we speak, I think, a little bit more of the language and so can explain what's going on up to a certain point. And then also we're going to talk about resources for further learning because you will not be able to walk away after tonight being able to do the work that we do, but hopefully we're just hoping to plant a seed to inspire you to get trained. And I believe it's well within the scope of almost all physicians, if not all physicians, scope of practice to do the work that we do, especially if you're a generalist, actually. So I'm going to mostly be talking about how physicians can assist with asylum, E-visa, and T-visa applications. And I think to situate that, I want to talk a little bit more about the way that refugees get to the United States, just to make sure that we all are speaking the same language here. So when you have someone who is a refugee, often that person has started the resettlement process when they are living in another country, either the country they originated from or another country that they might be staying in, for instance, in a refugee camp. And so a lot of the applications they're going through, which takes multiple years, sometimes an enormous amount of years, is happening before they arrive in the United States. They are approved to arrive before they cross the border, and they're brought here through the U.S. Department of State. And then there's an agency that assists with their resettlement, and they're on a pathway to citizenship. And again, you'll learn about how we can help for that pathway as well. Most of the work that I'm going to be talking about is in the world of asylum medicine. And so an asylee is someone who is trying to essentially say that they are a refugee, and we'll talk about what that means, but they're already in the United States. So they either were here on an active valid visa that has not expired yet, for instance, a student visa, and something has changed in the country that they came from, and it would not be safe for them to go back. And so they say, hey, I'm here legally. I don't plan to go back home. I want to apply for asylum. And so for that, they have an interview, and then based on the results of that interview, they either stay or they have to leave. There's other groups of folks who are planning to apply for asylum, but were not able to get a visa. And so in many countries in the world, it's challenging to get a visa. There's a lot that goes into why that might be, a lot of politics that goes into why that might be. And so they don't have a visa. So they arrive without a visa and say, hey, I'm here to apply for asylum. This is something that international law, there's a precedent for around the world. And so they present themselves to the border. They're not sneaking across. They get put in detention. They get what's called a credible fear interview. And then often they're released on parole while they wait for their court date. That's a defensive asylum process. And then last would be someone who, it's another form of defensive asylum process. It's a little bit more challenging. And that is someone who does not request asylum at the border. So they either, it's EWI or entry without inspection, so they sneak across the border, or they overstay a visa, so they don't have a valid visa. And now they're here and they get in trouble somehow, and now they're like, wait, you can't send me back. I want to apply for asylum. You can imagine that's the hardest to get. And usually ICE is involved in that process. So mostly we're going to be talking about people in the United States that are trying to say that they meet the same criteria that those refugees met who were approved in a different country, and therefore they should be able to stay and get put on a pathway eventually to citizenship. These are the criteria that people need to meet. And as a non-citizen, you are not guaranteed the right to legal counsel. However, of course, a lawyer is going to be really helpful, but lawyers are expensive. So someone needs to prove that they have a well-founded fear of persecution based on actions by the government or by persons the government is unable or unwilling to control. And this persecution is not minor things. It's not threats of violence even. It has to be threats to life. Either confinement, detention, imprisonment, torture, sexual assault, forced abortion, or cutting. So these are some of the things that are the degree to which you can say, I've been facing persecution by either the government itself or people the government can't control. For instance, I've had folks apply from Central America, and their argument was that they are at risk from the gangs in El Salvador, and the government cannot or will not control the gangs, and so therefore they need to be able to flee and live somewhere else safely. Also, the persecution can't just be because or about you as like an individual human, you got on the wrong side of someone. This really is someone who is saying that they're being persecuted because of their race, religion, nationality, membership in a particular social group, or political opinion, and that they cannot or will not return to the country because they're so afraid for their safety, and they can't get protection in that country. So if you're someone who is being persecuted with threats to life or imprisonment because of your race, which is a minority race in your country, however, the police would protect you, you just prefer not to go to them, then that doesn't count. You have to be unable to be protected by like a legitimate protection source within that country. Particular social group is pretty vague. This is where the art of lawyering comes in. And so it's up to them to really have to argue that this person is part of a group that has these different criteria. So just some examples of this are LGBTQ plus people, tribes or ethnic groups that are recognized, different occupation groups, child soldiers, and sometimes women, although that gets complicated. And so, for instance, occupational groups, I have seen it where, again, in an example of El Salvador, a police officer in El Salvador that was trying to disrupt the violence of the gangs there, and now is being targeted because they're a police officer that was not crooked and was trying to protect people from the gangs. And so therefore, because of their occupation, they are being persecuted and they can't get protection within that country. So once someone applies for asylum, then an important thing to know is that they can apply for a work permit after several months, and you should get a response within 30 days. So I want you to imagine these folks are showing up in the country, often without a work visa. It's often something that's more like a student visa that I've seen, and or arriving at the United States border, again, without a visa. They are not able to legally work for at least 6 months. If they were to try to work because there are bills to pay in order to eat, in order to have safe shelter, then they would probably be ineligible for asylum if anyone they would be ineligible if anyone finds out about it, because now you're breaking the law if you're working without permission. So just I think something important to think about for folks applying for asylum is this isn't a free pass by any means. And this is something that's always under threat, unfortunately, as well. But as of this moment, this exact moment in time, folks can often get a work permit. And within 6 months, ideally, if there aren't any more delays, they are working. The other thing to be aware of is there is a huge backlog of this. And so as of August, so a few months ago, 2.3 million immigrants were waiting for their asylum decisions. And that's across the country, but this number is just going up constantly. And as of 2024, I don't have more current data than that. It's about 3.9 years for an asylum hearing, or even an interview, actually. So again, some folks are getting interviews if it was a more proactive asylum application. And the lawyers that I work with are saying it's definitely higher than that. It's probably closer to at least 5 years at this point, because this backlog is only growing and growing constantly. In addition, we have about 700 or so immigration judges in the United States. And this is a recent article, you can see this was on NPR. You can see that some of the judges of those 700 that are trying to help with this backlog are being fired, especially if they have a background of working in immigrant defense. And so this is not something that people are not elected to be an immigration judge. You're appointed an immigration judge. This is a government appointment. And so when a certain administration is in power, then this can be relevant to who is allowed to be an immigration judge. And so there have been about 10% of the workforce fired despite this ever-growing backlog. This is just an example of a timeline. So again, best case scenario, someone applies for asylum January 2026. It's going to be at least 4 years before you have your hearing or interview. Say you're granted, then it's still going to be another year before you can apply for a green card. And then with a lot of other criteria, it's still going to be another 5 years before you can apply for citizenship. And so just, again, a reminder that this is a really long process for people. I want to spend just a little bit of time too talking about asylum decisions. And so, again, I had sort of said it really matters. This is actually very much political. And so you can see the percentage of people for whom asylum is denied. This is a really great website I have linked on the bottom here. It's called Track. And it has an immigration data clearinghouse, and it's free, and it's updated pretty regularly. So you can see that over time, the percentage of asylum cases that are being denied. And so you see a huge uptick again, even from 2025 compared to the year before. And so you're seeing it that about 68% of or so as of this data in 2025 were denied asylum. This is not the full year of 2025. This was only the partial year. So if we look back at the last full year in this data set, 52.2% were denied, but there's a huge uptick the next year. And we'll see once the final 2025 data is in. Also, unsurprisingly, much more likely to be denied if you do not have a lawyer. 80% of those without a lawyer are going to be denied asylum. This also matters based on the court that you go to, and that is just based on where you applied in your geography. So this is our court. Most of us are based in Cincinnati. Cleveland is the closest immigration court. That's like a 4.5-hour drive from here. It's across the state, and you see much higher percentages of people being denied in our court versus the national average. So some courts easier than other courts in order to get approved. And so there was a 71.5% denial rate in the Cleveland court in fiscal year 24. 2024. Again, it was 52.2% nationally. And the rates are massive, whether you have a lawyer or not, but nearly 75% of those without a lawyer were denied asylum. This was very recently published also. This is data just looking through August of 2025, and we see the asylum grant rate, which is that like reddy orange one, is just going down since 2023. And the percent that are denied are going up and up and up. So it's only getting harder for lawyers to help folks gain asylum. And my font did not look well here, so you're going to have to squint really hard. But essentially, the last column on the far right there is the percent denied, and these are different immigration judges. Again, this is public data. You have no control over which immigration judge is presiding that day. I don't think you actually even find out until the day of, and even just in the Cleveland court, that's our court, one of the judges has an 87.9% denial rate. So you're hoping if you're an immigrant that you're getting Judge Whipple as opposed to Judge Burke. We, as of last year, had an immigration judge that had, I think, a 97% denial rate. So I'm actually pretty happy that like this is looking better than it was last year. But still, depending on the judge you get, is going to influence whether or not you get asylum. There's another way to get relief besides asylum. So again, we've talked about asylum. For U and T visa, these are also things that physicians can help with. And so for this would be an immigrant who, for a U visa, is the victim of a certain crime, and there's a list of crimes that apply. Or for T visa, you've been the victim of human trafficking, often labor trafficking, although any type of human trafficking, I think, could meet most criteria for the T visa. This is a newer visa. These visas were both developed because of what's happening in this country is immigrants are afraid to report crime because they're worried if they report crime, they're going to be deported. And again, this is only getting worse in 2025. But so immigrants were not reporting when there was crime happening. And so therefore, crime rates are increasing. So they developed these programs where if you're the victim of a crime and or trafficking and you suffered substantial physical or mental abuse during the time of this crime and or human trafficking, and you agree to cooperate with law enforcement, there's actually a pathway to getting a visa for you. So this is trying to encourage people who have been the victims of significant severe crimes to report it, to work with the authorities to get the criminals who were oppressing them out of the United States. And so again, it would be protecting the folks who have been the victims. That is very much simplifying it, but I think you understand the intention behind the T visa and U visa. So when someone wants to apply for either asylum, U visa, or a T visa, where does a physician come into this? Because a lot of this is the lawyer's job to say why it would be dangerous for this person to return to their home country in the case of asylum, and or just to document that significant physical or mental harm happened to this person because of trafficking for T visa or the crime. Most of the ones that I've done there U visa are sexual assaults. And the lawyers need to document that harm happened and also should be saying why the person can't be deported to the country that they arrived from. So our job as physicians, the main job is to evaluate and document the impact of trauma or torture on health. And so that happens through a physical evaluation and or a psychological evaluation. And I would argue that, again, most physicians are qualified to do both of these. I can't go into detail about exactly what happens with this, but I'll tell you a little bit about what to expect. So when an immigration attorney that works with the nonprofit law center I partner with wants an evaluation, they're going to do an intake for people who are potential clients. The client tells them what's going on with them. They decide whether or not it seems like it's a legitimate case. And if so, if they are uncovering that there's been any evidence of even psychological harm or physical harm, then they might request an exam from us. For that, the client has written a statement about what happened to them that meets the criteria for asylum that we talked about. And the attorney is going to share that with me prior to doing the exam. And then during the exam, again, I'm going to have read through their statement ahead of time. And I tell them that because my goal is to re-traumatize them as little as possible. And I interview them about using a timeline approach of like their life, their health throughout different phases of their life. And then as I get some more details about some of the things that have happened to them, then I'm going to see how their mental health and or physical health was affected. So sometimes there's scars to evaluate, in which case I need to get pretty deep into the mechanism of how that injury happened so that I can write using some different criteria that exist that you will be trained on if you go through asylum medicine training,
how concordant the injury that I'm seeing is with that mark. I am not a dermatologist. I am not very good at even describing dermatologic different terms at this point of my career. But your audience for here is judges and non-physicians, and so not a dermatologist. And so your goal really is actually just to hear what happened to them and say, does this look like this could be a scar that would result from that injury? And then the other thing is mental health screeners. And yes, I am a psychiatrist. However, a generalist can 100% do the mental health screeners that I do. Almost always is a PTSD screener. And sometimes people actually don't have PTSD anymore based on the fact that they're in a safe place now, hopefully, if it's asylum rather than a T or U visa. And so I'm using the PCL5, which some of you might recognize, which is exactly the DSM criteria. It's a self-report thing that I'll go through. It's available in several other languages. I'm always having an interpreter with me, by the way, and it is the attorneys. I do these pro bono, and so I expect the attorney to provide the interpreter, and they're happy to do so. And then the RUDOS is another thing that I have only really used in my immigrant refugee work. And so this is a cognitive assessment. I like it a little bit more than the MOCA. The MOCA is great if you have folks who speak the languages the MOCA is available in. However, this is really developed for use across different cultural audiences. You can do it with an interpreter, and you'll notice like the things that you have to remember are tea, cooking oil, eggs, and soap. I don't care where you are in the world, there's a good word for those, and it's something that is culturally relevant to humans across the globe. And so you do this with an interpreter, and there's a scoring system that you can look up for it. So again, nothing actually that sophisticated. Sometimes I'll throw in an additional screening test for depression or anxiety, but often, like, really our job is to document is there PTSD or not. There's not often severe mental illness that these folks are suffering from besides PTSD, because they have had to go through so many things to get there. We can talk about this more at the end, but these are some ways to get trained. The Physicians for Human Rights Asylum Network, you can join, you apply for it, and some of their student-run clinics also run trainings on this. And then there are recorded modules that are free under the Asylum Medicine Training Initiative. So I'm going to pass it on to our next speaker, but just to kind of recontextualize things, say someone applied for asylum, we did an asylum evaluation. And this year, say we did it in 2021. So in 2026, they're granted asylum after the waits. Now they are going to be applying for a green card, and that's where I'm going to pass it off.
All right. Good evening, everybody. So I'm going to get into what in the heck is a civil surgeon? How and why would you want to become one, and what does it even involve? Because obviously getting your green card is an incredibly important piece of immigration, and especially now that we've seen all the changes that were built into the big terrible bill that was passed over the summertime. This is going to impact their ability to, immigrants' ability to get any kind of health care. Even they wouldn't even be able to purchase like subsidized in the marketplace, let alone be eligible for Medicaid or Medicare without the green card. So this is only becoming more and more important with time. You can advance. So a civil surgeon, this term seems a bit odd to me. So of course I had to figure out where did this come from. It's historic in its origin from Britain during the colonial times, where civil was meant to mean civilian, and surgeon was just a physician, public health leader in the colonies with a role of screening and preventing the spread of infections. So the primary role of the civil surgeon is completing the immigration medical exam to ensure applicants are meeting all CDC requirements by using the USCIS guidelines. There's fairly detailed guidelines available on the USCIS webpage. Anybody can view those, and I believe there's a link in your guide that you'll be getting in advance. So why should you become a civil surgeon? Well, because if we don't step up to do it, who is going to? This was not included for me in my training as a medical student or as a resident. This came out of the necessity of, in running a refugee clinic, having people ask me every day, what do I need to do for my green card? And I was like, maybe this is my lane. Maybe I need to know more about this. And so finding mentors that could teach me, what was involved in being a civil surgeon really helped me to step up and to become a designated civil surgeon. So not just anybody can do it. You do have to go through the designation process. But just to give you the scope of the problem, there were 8.7 million people in the U.S. eligible for that status adjustment in 2024, yet only 500,000 applications were processed the year prior. And application rejections are incredibly common. I've seen people coming for their fourth, fifth time doing the same exact paperwork. I couldn't find any apparent, things wrong on their previous paperwork. But it's not necessarily going to be explained. You just have to do it again and keep going. And I practice on the Kentucky side from Cincinnati, and we have had just a immensely growing number of immigrants over the last 20 years. In our state, we had more than 30,000 people currently eligible for adjustment of status from the most recent statistics I could find. Yet there are only less than 15 designated civil surgeons in our entire state. And realistically, maybe 5 or 6 that are currently practicing. So obviously there's this massive bottleneck where we just need more people stepping up that can do this paperwork. Oh, thank you. Also, let's paint the picture of why is it so important that immigrants even need our help? Because as you know, if you've worked with any immigrants in a medical clinic, there are a lot of barriers to navigating the medical system. There's also so many barriers on the legal side of things. So when you put those two together, it's really compounded and extremely difficult. Then we have to think about the financial barriers. These exams, I was having people come to me telling me they were charged up to $800 a piece. So think about a family, single mom with 8 kids. How is she going to afford getting this paperwork done? It's just not financially feasible for some people. And so then they forego the ability to even get their adjustment of status. And therefore they lose their ability to work legally and to get health care. So it's a really big deal. So what do you need to do to become a civil surgeon? It's actually not all that hard. You just need an MD or a DO with at least 4 years practicing medicine. It's suggested to have expertise with immigrants, but that's not actually a requirement anywhere in the application. Commonly, I find that civil surgeons are internists, infectious disease specialists, but there's actually no specialty excluded from the designation. And if you do sign on to work at a health department or a military site, you are automatically enrolled as a civil surgeon in those places. I've had a question of whether training like residency counts as this experience practicing medicine. And again, on the website, there's nothing excluding those years of experience. So how do you actually do it? You complete a form because everything with the government is with a very official form. So it's the I-910 you complete. You need a copy of your medical degree and license. You need proof of those 4 years of experience. So letters from supervisors. And just so you know, you have to have designation for a really specific site. So I can't just go out to, say, a jail if I'm asked, which is happening frequently these days. If I'm asked to do an off-site exam, I'm not allowed to do that. It has to be a site that was designated by USCIS as well. Once you are in as a designated civil surgeon, though, it's fairly easy to add on additional sites, such as with new medical legal partnerships. So I'm in the process of doing that here recently. We're going to quickly go through what are the medical requirements for immigration, just so you have some clue of what this job would look like. So we're going to talk about Class A and Class B conditions. Anybody that's seen refugees would be somewhat familiar with these classifications. But basically, Class A means do not pass go. These are inadmissible conditions versus Class B are admissible. They just need to be documented. So the inadmissible list is very short. Active, untreated tuberculosis, so coughing, fevers, etc. Untreated syphilis, untreated gonorrhea, untreated leprosy. Any physical or mental disorders associated with harmful behavior, so like history of harming another person and likelihood to do it again in the future, or untreated drug addiction. The Class B conditions are really vague from there. There are really specific classifications related to latent tuberculosis, where you would need a chest x-ray to put you into the different buckets of which classification that is. And then anything that is post treatment of a Class A condition. So treated syphilis, treated gonorrhea is now a Class B condition. Anything else, their examples on their website are hypertension, diabetes, or physical disabilities, but it's really any seemingly relevant medical problem that could impact their ability to work and function as a U.S. citizen. The required screening tests for the immigration medical exam are also a fairly short list and really depend on your age, what you have to do. These do need to be ordered by the civil surgeon. It's supposed to be done within 2 weeks of signing the paperwork as well. So the quantiferon gold is the blood test for TB that's required for anybody that's ages 2 and up. If you're under 2, there's no requirement as far as testing for the TB at that point. Syphilis test is required for anyone 18 to 45 years old, plus any reported risk factors such as multiple sexual partners. Gonorrhea is required for ages 18 to 25 and anyone with risk factors or reported symptoms. When you're taking the medical history for the immigration examination, again, it's going to be pretty targeted to these specific conditions. So we're not, getting, this isn't like a new patient intake visit necessarily. You can do it in that context and sign the papers as well. But if you're doing it just for the civil surgeon exam, it's just targeted. So any symptoms of TB, such as the chronic cough, fevers, night sweats, weight loss, any history of prior sexually transmitted infection, and current or past symptoms of a sexually transmitted infection, including chancre or rashes on the palms and soles, that would be indicative of syphilis. Any history of non-healing skin lesion or loss of sensation to indicate leprosy. And there's no blood test for leprosy. This is history and physical exam only. And then you do a mental status exam, ask about history of mental illness, history of harming anyone else physically. I've never had someone admit to me that they had harmed people, but we ask. And then drug and alcohol use, and does that rise to the level of being an addiction or abuse? On the physical exam, you do a basic examination with particular attention to mental status, plus the oral and nasal mucosa. So again, going back to the med school years, at least a lot of the people attending would be more familiar and remember with leprosy that this can cause erosion of the nasal mucosa and cause sores inside the mouth. We also listen to the lungs, looking for signs of TB, palpate for the liver and spleen or other abdominal masses, assess for any skin lesions. And very specifically on this list is sensation of the digits. So I check everyone's fingers and toes with a piece of cotton just to make sure they have normal sensation reporting. Of note, if there are sexually transmitted infection symptoms reported, you do not do the genital exam at this part of the civil surgeon exam. You wait until you confirm that the infection is there with testing before going back to do that examination. There are also immunization requirements. On the USCIS webpage, they are very specific about which ages require which vaccines, and that these need to be preventing a disease that has the potential to cause an outbreak. So of note, HPV is the one vaccine that's not included on this list since it doesn't occur in outbreaks. And also COVID-19 used to be on this list, but it was removed as of January of this year, which was very helpful. But the flu, when it's in season, is required for everyone, along with varicella, measles, mumps, rubella, hepatitis B, polio, diphtheria, tetanus, and pertussis. And you have to, if you're looking at the CDC guidelines, use the rules that are specific for immigrants and not for everyone. Because, for someone that, say, is 40 years old, this wouldn't be required or recommended to get a polio vaccine if they go to the pharmacy. And it definitely wouldn't be recommended to get like an extra Tdap if they just had one last year. But you have to get like the series as if you had never been vaccinated before. For people under 18, we add hepatitis A and meningococcal to that list, and under 5 as well, they would need Hib, pneumococcal, and rotavirus. Pneumococcal with the ACIP requirements just changed this year to being required for everybody that's 50 and older. So it's just things to keep up with. You have to be up to date with what are the ACIP requirements. Who knows what's going to happen with those in the next couple of years. I really hope nothing crazy, but it's probably going to happen. All right. And then for these vaccine requirements, it's also good to know that as long as they're up to date on the day that you're signing, as in they've had at least one dose of these and the next dose isn't due yet, then you can go ahead and sign that form. So a common misconception is that people have to wait, say 6 months for that next dose before they can apply for their green card, but that is not true. If they're up to date today, then they're good to go for the signing this paperwork. There's just a specific box at the end on the vaccine list that says that the minimum interval has not passed yet. If you do get vaccine records from overseas, you should count those. And so it's really helpful to know that, you can assume that if they have a valid looking vaccine record, you can trust that those were good vaccines. You shouldn't automatically throw those out. And you should, potentially have them translated, but we do have some tricks up our sleeve to help to translate those. Thank you. So VaxRef is a free resource where you can actually submit a vaccine record from overseas and have it translated for free. So this is a great resource. And then Google Lens is I've also found to be really helpful just in confirming. I'm like, I think I know what this means. And then with Google Lens, I can see, what the word is in English, and I don't have any doubts about it. Sometimes it's helpful to know just that the dates might be written differently overseas. And so like the day and then the month and then the year rather than month, day, year, just in case you come across those. If they do not have any vaccine records, you can confirm immunity for measles, mumps, rubella, varicella, and hepatitis B. Polio is on that list, but unfortunately, there is no lab test available in the U.S. for all 3 of the polio virus serotypes, and so they just need to get that vaccine. When you're completing, this is the form. When you are completing this form, you will see at the bottom of the first page, if they had an overseas immigration medical exam by a panel physician, this is the case for almost all refugees, they get to check this box and skip to the vaccine portion. So this is why, I felt like this was a pretty low bar. I can definitely do this and add this to my practice. And now this form just becomes like a sports physical. I'm just signing another form, confirming that they've met all the requirements for the vaccines and saved, families thousands of dollars. If there is a positive TB test, I always warn people, remember TB is very, very common in the world, like 1 in 3, 1 in 4 people. I was going to have a positive TB test. So I let them know in advance what we would do if it is positive, talking about getting a chest x-ray. The chest x-ray is positive, a sputum culture, and proceeding with treatment if they do have latent TB. As a civil surgeon, you're escalated where you're allowed to do the treatment without referral to the health department, unlike people who are not civil surgeons. For the syphilis evaluation, just another quick, tip is that the test needs to be done and a non-treponema test is required. If you do a treponema test, then you would have to also have the same blood sample do a non-treponema test. So you wouldn't be able to do 2 different samples on that. Just a reminder of some signs and symptoms of leprosy. So you're looking for erosion of tissues, non-healing rashes, and abnormal sensation. The other significant medical conditions, again, we touched on physical and mental disorders that may result in harmful behavior. If they do have a diagnosis such as schizophrenia, such as bipolar disorder, depression, etc., you consider how severe and debilitating the condition is. Consider how treatable the condition is. So you just add some comment on the extent of that disorder on their functioning, and have some comment on unlikely to result in harmful behavior or is likely to result in harmful behavior. So for people that I've seen with significant mental illnesses, getting a note from their psychiatrist can be really helpful to add to the application. For the mental health exam, you can, again, refer to a psychiatrist. Anytime that you make a referral on this form, you send the form with them. There's space for the specialist or the person that's doing the referral to fill in their portion, and then it comes back to you before signing it as the civil surgeon. But I agree with Dr. Stryker that most of us do have plenty of training and expertise to be able to do what's required for this exam. There is, again, really straightforward guidelines for all of these things. There's even an algorithm for if there is a history of harmful behavior or not. How would you manage it? And just wanted to touch on a couple of pitfalls. It is common for folks to come without any records, especially if they were a secondary migrant. So getting used to doing the tests and doing a good history so that you can, understand what medical problems are there or not is really helpful. Again, TB is common. We talked about that. And then being up to date on vaccines. A lot of people are told that they were up to date on vaccines, but don't understand that might be a temporary status. And the concept of the vaccine series needs to be explained. The paperwork needs to be completed absolutely perfectly. Every single box that needs a check needs to be checked. Otherwise, it will be denied. And then, of course, using an interpreter. And there's a place for that on the form because if they go for their interview and there's any limited English proficiency, they're going to call into question the validity of this form if you did not use an interpreter. So when in doubt, always use an interpreter. And then just want to comment on the benefits of this collaboration, like working alongside with lawyers. Co-location is so important because then when you know that you're working with people who have limited access to transportation and like trouble with processing times, this really just cuts out like a big piece of the problem of having to go here and then go there and then go get vaccines here and then come back. You just ensure that all the forms are completed and there's nothing like lost in the shuffle. Also, it is a requirement as of last year, the documents have to be submitted together. So their I-485 that they do with the lawyer and the I-693 is the part the civil surgeon does have to be submitted simultaneously. All right. Now, I think we're passing on at this point, right?
Yeah. So I hope that you are feeling convinced that there is a role for physicians in this space, and also that citizenship status is a health and public health issue. I'm going to take us to the next step. So we talked about asylum being granted. We talked about applying for the green card. I'm going to talk about a form that can be helpful around the time that folks are applying for citizenship if they have medical barriers. So that form is called the N648 form, and it is a waiver from the testing requirements that are associated with applying for citizenship. So there is English and civics exams, and this form can provide a waiver from one or both. And it can do that on the basis of physical or mental inability to study for and complete the exam. So it can be anything from somebody has dementia and is unable to learn the material to somebody has PTSD and is unable to like sit through the exam for the duration of the exam. Age alone and literacy barriers alone do not qualify somebody. So this is specifically based on a chronic illness or disability. And then I have seen sometimes folks get this confused with like general disability applications, and this is a distinct paperwork that is specific to this purpose.
And I messed up the timing of like the requirements for citizenship. Can I just like go back a couple slides to like put it up just to like contextualize this? I did that backwards. So sorry. Here was the requirements that I put in the wrong order here for like what people need to do to obtain citizenship, where those requirements are talked about.
And then, as I said, I think citizenship and citizenship status is a health issue, in particular at this stage in the game. When somebody has had a green card for 5 years, they become eligible to apply for citizenship. For refugees and asylees, if they do not apply for citizenship within 7 years of being granted their green card,
they may lose access to a number of social services from like ability to apply for um, benefits and SNAP and things like that. Citizenship also affords the right to vote, which we know is a public health issue and has health impacts, and can also increase ability to travel through provision of a passport. And this is a form that is submitted during the application for citizenship. The form has to be completed by a physician or clinical psychologist. One key thing to be aware of, which is true for a number of the forms that we've talked about, is just because you've completed it does not mean that that person is granted the waiver. Ultimately, it is the USCIS staff that will approve or reject the N648 based on how it is completed. I'm going to speak briefly about some of the portions of the N648. This is one where it can be completed either by somebody's primary physician or by a third party. I think the important thing is that we maintain integrity in completing these forms, but it can be helpful to know somebody's health history. So if it's something that you would want to incorporate into your practice and you feel like you have a good enough understanding of how to complete them, and you feel like you have the ability to communicate with that patient's lawyer, I think that's reasonable. I also think when I completed a number of these, it was through a medical legal partnership, just so that those lines of communication between physicians and attorneys were open. So could go either way there. But just to walk you through the form, the initial part of the form is essentially housekeeping stuff to identify the applicant and identify you as the person who's completing the form. The section on the next slide is really where the money is. This form used to be much more complicated, have significantly more parts. It's been consolidated in a way that me editorializing, I think is great. And I think it makes it much easier to complete. But essentially, part 3 is what is going to make or break this application and whether or not it's approved. So this asks you for the clinical diagnoses for any physical, developmental, or mental illnesses or disabilities that the applicant has that specifically would impair their ability to complete the English or civics requirement, and asks you to specifically say why each of those things prevents completion of those requirements. It's important to remember who your audience is here. I think these are often connections that seem very straightforward to us. For example, if somebody has severe dementia, it seems like it shouldn't necessarily require explanation as to why somebody couldn't learn civics information and complete an exam. But it's important to connect those dots very linearly and to use non-medical terminology, because this is ultimately going to be approved or denied by USCIS. After you've completed that portion, there are a few additional questions that is important to be aware of. So there is a question about how the diagnoses mentioned in the previous question we just went through were made. That can be tools like the mental health screeners that Dr. Stryker was discussing. It can be just this person meets diagnostic criteria for this condition as published in this guideline. And it can be laboratory testing. I find that for the majority of these that I have done, it is often mental health or cognitive diagnoses, and leaning on diagnostic criteria or screeners is completely appropriate and often what I would do here. 2 things to be aware of. Could you go back just the one slide? 2 other quick questions to be aware of. You are asked whether or not this condition is expected to last more than 12 months. If the answer to that is no, the patient does not qualify for this, which makes some sense when you think about the intention of the documentation. The rationale as well, they should just apply when the illness resolves. And then if the disabilities are directly linked to use of illicit drugs, that is also disqualifying. And then on the next slide, one of the final portions is, would somebody be able to understand the oath of allegiance that they would take as part of becoming a citizen? And so this is arguably in part to protect the folks who are like the applicants to make sure that nobody is like coercing anybody, but to also make sure that they understand um what it is they are saying as they take the oath of allegiance. If not, then there needs to be interaction with like legal guardian or a surrogate to make that determination, and that can be done as well. And then I do recommend generally going through interpreters, and specifically gives you space to document who your interpreter was. And then the last couple of portions are really just signatures and additional housekeeping, and then your credentials. So I think in summary, there are multiple different medical legal opportunities across the immigration journey where physicians have the opportunity to support folks in navigating immigration pathways. And the opportunities that we talked about are roles that physicians and other healthcare providers in some cases need to fill. And there are opportunities to get this training that is, for the most part, not specialty specific. And so it's an opportunity for any of us to kind of step up and fill these roles. And we are happy to take questions in our remaining 8 minutes.
Thank you, all three of you, for your amazing presentations. I'm going to start with the question at the top from Miriam. Have there been any recent changes to asylum for people who are trans? What would you advise a woman who was assigned male at birth who has her final hearing for asylum scheduled soon, including new things like new dangers, ICE harassment, pickups at court, etc.?
That is such a difficult question. Most of my 75% of my patients in my primary care practice are trans. And so I often am actually, I try to do as many of these for LGBTQ plus folks as possible. And it is very weird in 2024, 2025 to be talking to an LGBTQ plus person about getting asylum in the United States when it feels so unsafe here. There is nothing official so far that is saying that people cannot apply for asylum in the United States on the basis of being a part of the trans community at this point. But I think that your questions are very well appreciated, and what you would advise someone in terms of potentially like having dangers. And so it is difficult, but I would say that just in this current environment in general, where you are going to be in a setting that is confrontational, to just sort of to not draw extra attention to yourself in general as much as possible. But obviously be yourself, be truthful. And as of now, it is still, it's very clear that in many other countries, it is actually even worse than the United States to be a trans person. And so be honest, but frankly, I would say probably be a little bit androgynous in your dress, but also like be authentic to yourself, because if you were to show up, if a woman was to show up wearing a suit and tie and short hair, then I think that the other lawyer would question whether this person was really trans or not. In general, the court setting in particular is very confrontational. And so the opposing counsel is always just trying to say this person is lying. They were coached at the border. They're not really trans, etc. And so be authentic to yourself, but also just be aware that you don't know what's going to happen. And safety is difficult to assure, and also important to kind of recognize. So that is not the best answer, but that is kind of what I tell folks.
Amazing. Okay, our next question is from Patricia, and thank you to both Nicoles for answering questions in the chat as well, given we have an abundance of really awesome questions. Okay, this is a one from Patricia, planting a seed. She has read this article about judges in immigration court ruling to dismiss asylum claims because they have not been heard or in the appeal process. Could these be considered unethical or unlawful, such that they could be subjected to disbarment? Do judges in an immigration court have to be lawyers? And then kind of an ode to World War II Nazi times, kind of towards the end.
Yeah. Absolutely unethical, unlawful. Again, I'm unfortunately going to have to defer that one to the lawyers in the group. There is a lot of shady things happening right now. And so I would argue, yes, my impression is that, yes, they all do have to be attorneys to be an immigration judge. However, you do not need to have been an immigration attorney, which is so funny because immigration law is a very complicated form of law that is constantly changing because it is subject to political whims. And so that is what I have heard from my immigration attorney friends and colleagues.
We have a really interesting question about understanding of the changes coming regarding eligibility for medical insurance for refugees and asylees. For example, timing of when these changes will come into effect. Will states still be able to provide additional benefits? Any good sources for getting up-to-date information?
That is a great question. If you look at the at what was passed into law, there is like a timeline of like things rolling out. So, for instance, I believe like refugees on Medicare, if they did not already have it established, they would have already lost it now. There are other changes that go into effect like in January and some like October of next year, I think. And so there is like some time for folks to get their green cards in advance, um, but it's I think it's going to be a continuing moving target. The question about what states can do. I believe another change that was enacted was if there are new refugees, which currently there are not, other than folks from South Africa, which at least in my state we are not accepting, that previously, as long as they like applied, that they would be able to like access benefits in that interim before officially like getting granted like Medicaid. Now that part is gone, and so it would be up to the state to fill in the gaps and decide whether they wanted to cover that portion of time that they didn't have Medicaid. So I think there are a lot of changes that are going to continue to come down the line. But for now, people that have the insurance have not lost it yet, but they will probably next year.
Okay, I think we have time for one more question, and then I'm going to really quickly do the rest of the housekeeping stuff. Could you all speak to how clinical evaluations can support motions for safeguards pursuant to matter of MAM? I'm not entirely sure what that is.
I have not been asked to assist with one of those. Yeah, I'd have to consult my immigration attorney partners to ask what type of exam they would be needed. From my understanding of that, I think it would have to be a more thorough evaluation that I intend to be doing in the cases where it is essentially just trying to support the fact that what they're saying happened to them actually happened. And so what I understand about that would probably require a psychologist. But I would have to ask my immigration attorney partners.
Amazing. Okay. I would
Can I
like
really quickly answer the one last question? There's a quick answer to it. So can physician evaluations help someone be granted asylum? Thank you for asking. Absolutely, yes. The lawyers are so appreciative. They wish they could have one for every person. There was one study done for Physician for Human Rights that looked at 11 years of data of the national grant rate for asylum was about 42 or so percent then. And when they were having physicians do medical evaluations, the grant rate was 89 point something percent. So almost 90% of those who had a physician evaluation as a part of their case were granted asylum, as opposed to 42-ish% of folks who, which was just like the national average. And so it can significantly impact the outcome when we are able to give our medical expertise to help tell the story that, again, what they're saying is true and what they went through was bad enough that it left some scars, whether they are psychological or physical.
Amazing. I think that's a great note to kind of close this session. Thank you again to Drs. Stryker, Bashir, and Damari for their amazing thought-provoking discussion. We are grateful to have you here to join us. We have a written guide that's kind of like a shortened summary of what we chatted about to accompany this event that details all the pathways we discussed. You can find that linked in the chat, which Raya will put in, and it'll eventually be up on our website. Before you leave, here are a couple quick reminders. Please watch out for additional opportunities to provide input on future policy issues. And for those of you that are paid sustaining members of DFA, just a reminder to complete the survey for 1 credit of CME for attending this session. In addition, if you enjoyed this Advocacy Grand Round session, please consider supporting DFA's work and impact with a financial gift. The link to donate will be in the chat. And thank you, all of you, for being here, for all you do on behalf of patients. We hope you will become an official DFA member today, and take a look at the benefits of membership on DFA's website. The number one reason doctors, medical students, and health advocates join DFA is to be with like-minded people that share the same values and priorities. Thank you all for joining us. This was such a great discussion. I really appreciate you all attending and for learning more about this and for helping to support our immigrant patients. Have a great night. Thank you all.